Good morning, everyone. Thank you for joining for the Public Safety Solution for the SUD ECHO. This is brought to you by Be Well Texas and the Center for Substance Use Training and Telementoring, that's CSTAT. My name is Andrea Roche. I'll be facilitating our discussion today. Really glad to see so many faces here. Just some housekeeping before we get started. As you just noticed, these sessions are recorded, and those recordings are made available through the Be Well Texas YouTube page after the session. So if you ever want to refer back to any content delivered, you can check that out. Do know that these sessions are enabled for live closed captioning. If you want to view the closed captioning for this session, go to the bottom of your Zoom window and select the Show Captions option. You might need to click on that 3 dots or the More menu over on the bottom right of your Zoom screen to access that feature. And if you're having trouble finding that button and trying to get to closed captioning, message Kato at UT Echo IT, and she'll help you out. To help us with attendance, please use the chat to enter your name, your affiliation, and your email. Again, to access that chat feature, just go to the speech bubble icon on the bottom of your Zoom window, and it'll pop up. If you are a Be Well Texas provider, make sure you identify yourself during the session in the chat if you join by computer, or if you join by phone only, make sure you send that phone number and your information to the Be Well Texas team at bewelltx@uthscsa.edu. Echo IT is going to put that email in the chat in just a moment. We encourage everyone to join by video for the discussion portion of this session, which happens in the latter half. That said, regardless of how you're showing up today, we're glad you're here to learn alongside us. As just a reminder, there are a lot of us here, so please do stay muted unless you're speaking. Again, we encourage everyone to speak. If you join by computer, mute and unmute using that microphone icon in the lower left of your Zoom window. If you're on the phone, press *6 to unmute. You can also use the reaction menu in the bottom of your Zoom screen to raise your hand and indicate you have a comment to share. But that's really only if there's just a lot of conversation happening. You can also enter information into the chat, and we'll bring that information over into the rest of our discussion. Just note, regardless of whether you're chatting or speaking up, no protected health information is allowed in this session throughout its entirety. Keep an eye on that chat feature. Towards the end of the session, Echo IT is going to send out a link to an evaluation survey. And we want you to fill this out for a few reasons. It helps us think about content for future sessions and what the learning priorities of this community are. And it also enters you into winning a free $30 Walmart gift card. We're also approved for CEs for paramedics and any public safety professionals with a behavioral health degree. So filling out this survey allows us to give you that credit. Okay, really excited for today's session. We're going to start with a presentation for, exploring the relationship of reducing crime and overdose with medications for opioid use disorder, specifically about diversion and deflection in justice settings. And then following that, we're going to hear a case presented from Cynthia and Lisa with the U.S. Probation Office. And then we're going to get into that best part, the group discussion. So there are a lot of professions, a lot of experiences represented here today. So I encourage each of you to share that expertise with this group. Let's learn from each other. Let's challenge each other and grow together. So we're going to start with some introductions of our hub team and then our presenters for the day. I'll start with you, Jeremiah.
All right. Hi, everybody. I'm Jeremiah Golka. I'm Executive Director of the SHIELD Training Initiative, which is an outfit where we provide occupational safety, health, and wellness training to first responders and folks across the criminal justice system. Really glad you can be here for this discussion today, and I'm really excited for Dr. Del Pozo's presentation.
Thank you, Jeremiah. Cynthia.
Hi, my name is Cynthia Mendiola. I'm a retired federal probation officer, and I also work with CCS Incorporated as a trainer and a coach.
Thanks for joining us. Dr. Miramonte.
Good morning. I'm Dr. Dave Miramontes. I'm the medical director for San Antonio Fire Department, and we do a lot of work in this space, Suboxone therapy inductions, and harm reduction in the opioid space.
Thanks for joining us. And to our case presenters, Cynthia.
Good morning, everyone. My name is Cynthia Gonzalez. I'm a probation officer with the U.S. Probation Office. I'm happy to be here.
We're glad you're here. Lisa.
Hi, I'm Lisa Neal. I'm a senior probation officer with office here in San Antonio. Have been with the agency for over 20 years, and yeah, Cindy and I are glad to be here. Thanks for asking us.
Great. And I'll turn it over to you, Dr. Del Pozo, if you could introduce yourself and then take it away with the presentation for today.
Thank you very much. So my name is Brandon Del Pozo. I'm an assistant professor of medicine and public health at Brown University. Before that, I spent 23 years as a police officer. So 19 in the New York City Police Department and 4 as the chief of police of Burlington, Vermont. You might be thinking that is way up in this far corner of the country that's far from Texas, but hopefully the science translates from region to region. And I've had the opportunity to come to Dallas and to Corpus. I know to call it Corpus, to give some of these talks, and I've always had a wonderful reception. So I'm excited to be here today for about 20 minutes to present on this topic. Just going to get myself situated. I presume folks can see my screen.
Looks
Great.
good.
All right, perfect. So that we're going to talk about reducing crime and overdose with medications for opioid use disorder. So this is called either diversion or deflection. I noticed there are uniformed folks in the audience today. If you are not a person serving in a police or enforcement role, you can use this as fodder for an argument when you're trying to convince your colleagues in enforcement to go along with the public health approach. So just a minute to acknowledge my funding sources. It is the National Institute on Drug Abuse. We have 2 grants out of the Institute that have funded this research and this presentation. So thank you to the American taxpayer. I have no conflicts to disclose. And these are the learning objectives for today. So we're going to understand deflection as a prevention-oriented upstream public health intervention in justice settings. We're going to recount the public safety outcomes of linking people with who commit crimes to effective treatments for opioid use disorder. And we're going to understand the principles and elements of a deflection program as an alternative to arrest for people who have opioid use disorder. So I usually start with this. This is the premise, right? The premise here is that the deflection of people who use drugs, whose criminal behavior is driven by the consequences of drug use, is actually an intervention to reduce to increase public health, to increase public safety. And deflection as an alternative to arrest, I'll argue by the end of this presentation, is actually a core role of the police, not a deviation from police work. So coming from my hometown, New York, this is actually the New York City Charter. It was ratified in 1961, the version that we're looking at now. And I highlighted one aspect of it, which is guard the public health. It is not just law enforcement, not just public safety, but in the NYPD and in many other agencies of spirit, if not in the charter, it's a distinct mission of the police department to guard the public health. It's not some side experiment or an alternative tangent. It's part of the main mission. I also underlined below that the agency's tasked with the proper protection of life and health, right? So again, it's not just about enforcement, and you'll see why I say that in a moment. I've given this slide in Corpus and a few other places, but it drives home. If we're looking at policing as a life-saving activity, and we're looking at the things that cause death as things that police want to reduce, we can look at where the data lies about what the biggest threats are, right? So roadway safety is a big job of the police. Typically, traffic enforcement is a role in every police department. Car fatalities hit a peak in 2021. They rose at the fastest clip in nearly half a century. That was 46,000 traffic deaths. So we have this national role of police and traffic safety to lower this 46,000 death toll on the roadways. Homicides were up. This was a big thing that happened in 2021. It was a record increase in homicides, right? Again, that's clearly within the remit of policing. There were 19,400 homicides in 2020. That was the peak, right? This is, in interest of time, I'll just give it to you. This is the total number of U.S. service people killed during the Vietnam War over 10 years. 58,000 died at war. Not about public safety, but just putting this in perspective. When it comes to public safety, 105,000 people died in 2021 of overdose, right? So if saving life is the job of policing, it is 5 times the homicide rate, double the roadway safety rate, more than everybody who died in the entire Vietnam War. How can the public health and public safety for overdose not be a primary concern of law enforcement? It's also about, in law enforcement, not just a boutique form of public safety where you have the safest block in a city, the safest street. You really want the entire population to become safer. No chief of police says, I created the safest street in my jurisdiction. They say, I've made my entire community safer. Making entire communities healthier is the goal of public health. It's a natural affinity between the two. The other thing that we stress in good policing and good public health is prevention, right? You don't just want to respond to every shooting and solve it. You don't just want to arrest every person who does a robbery. You want to prevent robberies and you want to prevent shootings. The holy grail of public health is prevention. There are 3 levels of prevention: primary, secondary, tertiary. Primary is restructuring society so that there's less need to start smoking, less need to do drugs, so people eat healthier to begin with. That's not part of policing. That's way up above a police officer's pay grade. Secondary prevention is stopping bad situations from becoming worse. And tertiary prevention is about stopping bad situations from taking a toll in the instant. So policing is about primary and secondary prevention, right? When we look at this sideways psychedelic squid that was paid for with taxpayer money to represent the criminal justice system, we can see that if you go upstream to where policing works, you can have the biggest influence on the biggest trunk of this tree or body of the squid, whatever you want to say. So there's a lot of work in the community corrections and probation space about keeping people from relapsing, about medication-assisted treatment on probation and parole. We're getting more of that when it comes to being incarcerated, right? And treatment in jails and prisons. There's more efforts as well during the adjudication process to divert people towards drug courts, problem-solving courts. But all of those lines in the squid, so to speak, are kind of skinny. They're not treating that many folks. When you get into the policing space, you're dealing with 65 million contacts a year, hundreds of thousands of people of which have a problem with substance use disorder who could benefit from an intervention at that point upstream in the cycle, right? I'll skip over this quickly. Jeremiah is on this call too. He actually was the lead author on this paper. One of the things that's important about a police and public safety partnership is it's not just about the numbers of arrests. It's not just about the numbers of tickets. It's not just about the kilos of drugs seized, but are you actually downstream saving lives? Are you reducing that 105,000 person death toll, right? And also sometimes policing has negative effects. You could take a person, lock them up, right? You're taking them out of the mix. Maybe they're not committing crimes. It's going to be harder for them to get a job when they get out. It's going to be harder for them to go back to the same circumstances that they were in before and just succeed as if nothing happened. So we also want to be mindful of that. And deflection helps reduce some of the negative consequences of police work. Deflection also measures lives saved and people recovering from SUD rather than just saying, hey, I made 20 arrests this month, or, I seized 2 kilos of drugs. So it is a nice conceptual way to combine public safety and public health. When it comes to what the most effective interventions are, and I know there's a lot of folks who are quite well versed in this in the audience, but maybe there are folks in the first responder space who aren't. When it comes to people whose criminal behavior is driven by substance use disorder, particularly opioid use disorder, medications are the most effective answer, period. I usually spend several slides talking about this in a longer presentation. In the interest of time, I'm just going to say it 7 times loudly and repeat myself and show some slides. But by far, whether you look at, in this case, 50,000 or 100,000 or 200,000 insurance claims and see who did get medication and who didn't for opioid use disorder and see if they died or were rehospitalized, it's not naltrexone. It is methadone, and it really is Suboxone and buprenorphine, which are basically the same thing, that saves lives and prevents overdose death and prevents rehospitalization for opioid use disorder. So the fair question is, well, what does that have to do with crime? I'm talking about saving lives. Police not only have to save lives, but they also need to increase public safety, right? Would it be great if the medication could do both? Well, we have medications that can do both. This is a 30-year-old study about methadone that looks at self-reported crime days before people who had opioid use disorder started on methadone, and then self-reported crime days after they've been on methadone. You can see that it goes from 257.5 crime days a year, which is meaning buying drugs, selling drugs, sex work, theft, fraud, trespass, anything related to the outcomes of addiction. And then once you get on methadone as a medication, that number drops 70, 80, 90%. And if you look at the x-axis, it's not just for a year and then you're done, then you're back out and you're fine. These are people on methadone 4, 5, 6 years, right? It is a lifetime process to be in recovery, and medications could be a lifetime aspect of recovery. But when they are, it greatly, greatly, greatly reduces crime. Now, you would say to yourself, well, it's not zero. Yes, people still commit crimes. Find me the police department that presides over a jurisdiction where there's no crime, and I'll show you I just won't believe you, frankly. I'll show you a utopia, right? So it's not about reducing all crime, it's that methadone reduces crime very substantially. In fact, if a chief of police can get on a newscast and claim this type of citywide crime reduction, they'll be hailed as a hero, right? The other question is, how about buprenorphine? So this is not a deflection study. This is a jail study out of Western Massachusetts, but they had 2 adjoining counties with very, very similar populations. And one of those counties was giving its inmates in jail buprenorphine, and the other one wasn't giving them anything, right? And then they compared the outcomes of these 2 very similar counties over the years, and they found that when you give a person who needs it buprenorphine in a jail setting, and they continue it when they get out, they have a much lower incidence of rearrest. They have a much lower incidence of reincarceration. So it's not just saving lives, right? Which is the first slide. It's not just that methadone saves lives and reduces crime, but buprenorphine, when given to people who commit crimes driven by addiction, reduces rearrest and reduces reincarceration. So it's not only a public health medication, it's a public safety medication as well. That's just highlighting that conclusion. So reassessing arrest, right? This is just the International Association of Chiefs of Police and University of Cincinnati did some work on what it means to explore pre-arrest diversion. And to be clear about it, what it is not after arrest and arraignment, a problem-solving court or a drug treatment court. It is diverting people to medication-assisted treatment before you charge them with something. So we'll get to this in the end of the slide presentation. Is this going to be for robbery? No. Is this going to be for violent crimes? No. Is this going to be for somebody who commits the same crime again and again and again? No. But if you're committing low-level crimes, misdemeanors, theft, car break-ins, in some cases burglary, maybe drug possession, diverting the person to treatment rather than arrest is what we mean by deflection and diversion. So, some folks might say, what's that going to create? Just a revolving door? We're sending them to treatment again and again. As a 23-year police officer, I've arrested hundreds of people. I've also, as a supervisor, presided over the arrests of hundreds of people. The misdemeanor court system, without any of this, is a revolving door, right? You'll arrest the same person for theft or car break-ins again and again and again, send them into a carceral setting. They get out. What do? They recidivate, right? Here, it might take 3, 4, or 5 times to connect the person with treatment, but I guarantee you the treatment is more effective at eventually stopping the behavior than simple incarceration. And in some cases, if people continue to recidivate after being offered treatment, then they are put into the criminal justice system. But we're talking about pre-arrest diversion or deflection. So you would bring them maybe, like in Chicago, for example, they have a citywide deflection program where the person is brought in handcuffs to the station house. They are presented to the desk officer. At that point, their information is taken, a report is created, then they're screened. And if they qualify, they get hooked up with treatment, never charged, never sent to court. If they don't qualify, they go through the court system. I'm saying this because it's not like you're letting the person go scot-free with no record or no consequences. They're still being removed in handcuffs. They're still going to a precinct. And then if they qualify, they're getting treatment. And you're creating a record to see if it's working and to see how many times they've done this, right? And you're also sending the message that you're not just letting somebody go from the scene, you're letting them go from handcuffs in the station house, but a social worker and a clinician are waiting to screen them right then and there to decide whether to divert them or to send them through the justice system. So if you've seen the sequential intercept model, right, there's different points you can intervene on somebody's path through the justice system where you can give them, for example, treatment for addiction, right? So intercept 0 is before they even come into a police encounter, right? They're just, the community gets to them first, hooks them up with treatment, they stop committing crimes to, feed their addiction. Intercept 1 is when the police officer comes there and does it. And then intercept 1 into 2 is at the time of arrest. That's what we're talking about. We're talking about intervening there rather than sending people through the other 5 intercepts of the criminal justice system. It's an early preventive upstream intervention that can reach thousands of people in a jurisdiction, right? And it's being used. The law enforcement assisted diversion technical support group, I'm getting their name slightly wrong, is giving technical assistance to dozens and dozens and dozens of agencies throughout the state. Texas is a big state with very few of those dots. There are lots of other states that are in the process of doing this. So this is a growing practice. This isn't something that just some dude who was a police chief in Vermont once did, and has a boutique love for it. This is something that's getting some nationwide traction. So these are the ones that are exploring, developing, launching, and operating. And I would say that this is what the lead knows about. I'd say there are dozens and dozens of others that are operating below lead's radar, right? So this is not reinventing the wheel. This is something that's already growing throughout the country. There are some challenges to this, right? And this is one of the things that sometimes surprises people, but if you're a cop, this is true. Police have a tremendous amount of discretion as to whether they arrest somebody and charge somebody or not. If a cop is looking to not make an arrest, listen, I've been a chief of police, they'll find a way, not for robberies or rapes, but for low-level crimes, find a way not to make that arrest. If they want to make that arrest, they'll find a way to make it. So we want police to use science and evidence and not just opinion or whim, or whether they have to be at soccer practice after this to make the right decision, right? You don't want bias creeping into the process. So, one of the things that I did, and again, Jeremiah is on this paper as well, is we asked cops in 3 different states and dozens of police jurisdictions, do you have the power to make these decisions or not, to arrest or not arrest, to divert or not divert, to charge or not charge? And you wouldn't be surprised to know, if you were a cop, most say yes. In fact, when it comes to misdemeanors, I alone have a lot of control over whether I make those arrests or not, right? It turns out when we looked at other cops, the other variables, the amount of stigma you have toward people who use drugs, believe that they're liars, that they're dangerous, that they're beyond help, that made a cop more likely to arrest and less likely to divert. But also, if police officers believe that their supervisor supported diversion, that their chief supported it, that the community supported it, and that it would actually make a difference, those cops are much more likely to support diverting as well. This is some of that data in a table format, right? You see, if you build up this virtuous cycle of community support, agency support, and police understanding the evidence that this works, you get a virtuous cycle of willingness to use the program, right? But there are some barriers. For example, this is a study we did in St. Louis that just shows some of the barriers, which is addiction treatment with buprenorphine or methadone reduces a patient's criminal activity. 30% of the respondents who were St. Louis cops, they just didn't know. And another, looks like 30 something, almost 40% disagreed. That's just not what the science says. It's not what the evidence says. It's not what the experience says. Just cops haven't been trained in this knowledge. I haven't published it yet, but I have just under 300 US chiefs of police ask them the same question. A majority of US chiefs of police don't even know what buprenorphine is per se. So that's no one asked them to become pharmacologists, but if you're asking cops to make a difference in the overdose crisis, we need to have them understand the evidence that these medications not only reduce overdose, but the medications also reduce crime. So we do need to train our police workforce in this type of stuff. And then I will say, this is not a get out of jail free card for everything, right? This is part of that IACP report. There will be times, and I fully agree as a person who's worked in both worlds, where arrest is what has to happen, right? Violent crimes, people who are longtime recidivists where the intervention's just not working, people who sell drugs not as a subsistence thing, but for profit, right? If you're just profiting off other people's addiction, rather than selling drugs to your buddies to keep yourself supplied, like that should disqualify you, right? Again, violent and felony offenses, Sometimes state law prohibits the use of deflection. And again, it really, you can see when you're looking at this slide that violence is, I think, where minimum where we draw the line on deflection, because that's just not fair to the victim as well. And violence, carries its own inherent risks. So this is some guidelines, right? I think one of the things we see, I think I have like 1 minute left, so we're coming in right on time. You want to establish clear objectives when you do a program like this. You want to empower officers to say it's within your, not at the end of the month, I'm going to ask you how many arrests you've made on your performance report, but I'm not going to count equally how many successful referrals you made. And also, when you need the right community partnerships, we've seen in a lot of jurisdictions everywhere in America. I guess I'll close by saying this. Everywhere in America, from Washington State to Florida, from the bottom of California up to Maine, if you arrest somebody, the officer knows how to get that person charged and in front of a judge in a matter of hours, everywhere, 24/7, 365. We're asking cops to deflect and divert people to medication instead of arrest for opioid use disorder. Most cops would have no idea how to do this. And in a lot of jurisdictions, it's a complicated process that takes longer, or it might be only open like banker's hours, right? Like from Monday through Friday, 9 to 5. So one of the things I'll say for jurisdictions is if you want this to become something that police embrace as routine practice, it needs to be as easy and effective and clear of an option as arrest is right now. And cops need to get just as much credit for doing it. So thank you very much for this 21 minutes of your time. And I'd love to hear any questions if you have them.
Thank you, Dr. Del Pozo. What a compelling presentation. That was really, really terrific. Yeah, keep those questions coming. We have a couple from Amy in the chat. Amy, feel free to unmute and sort of offer some clarification if that's needed here. But first question being sort of the role of the LCDs. So how are LCDs able to help with providing substance use counseling for clients in the judicial system? Asking, is there contract work available with the judicial system as a private practice, providers, referrals? Any thoughts on that from the group?
I have no idea how to answer that question.
That's a good answer though. Like it's unknown. Any other thoughts from the group here? Understanding of the role of LCDs in this process.
I have a question for our speaker.
Mhm.
Just a quick glance at the map that you presented with the dots on where this is being carried out. There were not very many in Texas. They were mainly on the East Coast. Any idea why or when that might come this way?
Yeah, I think, it's funny because this is probably the third or fourth time I've talked to a Texas audience. And among police in Texas, there's at least a willingness to try this out, as well as like a genuine curiosity. Part of it, I think, is that the opioid crisis, if you look at the stats, is not quite as acute in Texas as it was in the areas where there's more uptake of this. I think the other thing too is that geographic concentration in the Northeast, like it takes half a day to drive from any jurisdiction to any other. So there's more like rapid diffusion among those agencies. And then some of it, I would just, to be honest, is an unfortunate, like, not to say regional bias, but a lot of the heavy hitting, like addiction science, nothing about, listen, I'm not San Antonio is aces, but I'm saying you have like all of these pioneering from Brown to Yale to Harvard to, they're all within like an hour's drive of each other. And there's this like little hotbed of like innovation in those settings. And I think that's where this sprung up.
I have an answer for the LCDC question.
Yeah, thank you, Cynthia. Please do.
And the question is LCDCs, is there contract work available? And I know I can answer to the federal side, and there are contracts, but they've got to submit the contracts into the federal system to get approved for that. But there are also contracts that they can do in the areas where they don't have a lot of counseling services. But I guess the question is it available? And sorry, I thought I had it on silent. Is it available and do we use those services? And we do.
Yeah, thank you. The reason I asked the question is because I live in the lower part of Texas, which is the Rio Grande Valley, and there's a limitation of services available. And I know there was a facility that I used to work at before we would do the pre-trial diversion counseling, where they had all these requirements and they had to do is complete their, like if they were ordered for the TDLR, the drug offender education courses. And then after that, they have to do so many hours of community service and then do substance counseling. So that's why I was just wondering, you know, how can me having a private practice be able to expand that to be able to provide that service? You know, because that's where you catch them, and like, you know, our presentation says you catch them there to avoid, you know, all these other issues where, you know, it could just be something that they just needed. But thank you.
Yeah, well, in the county level, there's the pre-diversion programs. They usually also provide the opportunity for contract, you know, to submit contracts, and you can usually go into their offices and just talk to them about the process. In the federal system, it's what we call RFPs, and I don't remember what RFP stands for. I don't know if Lisa or Cindy Gonzalez remember what the RFP stands for, but I don't. That's for the federal system.
Awesome. Thank you so much. Yeah, there's a lot of little, what is it, acronyms that they use?
Great question, Amy. Oh, Cynthia, go ahead. I saw you on mute.
I was just going to comment, I don't remember what it stands for.
Too many acronyms in our lives. Jeremiah, I saw your hand there.
Sure. Thank you. So a quick question, and so Andrea Yatzko in the chat pointed out that there are lots of other programs in addition to LEAD, and so this stuff is growing, but there are some areas of opposition to medications for addiction treatment among law enforcement. And Dr. Del Pozo, I thought maybe if you could take a quick second to talk about where some of the concerns and whether those are correct or kind of ignorant beyond the actual just unawareness of MAT. And I'm thinking such as, concerns about diversion or the kind of notion of trading one drug for another.
Yeah, no, that's a whole other, normally this is part of a 1 hour presentation that does cover that. Andrea brought up a great point, which kind of also answers, the answer I'll give kind of addresses Catherine's question too, which is you don't just have to go right into pre-arrest diversion, right? If you like, Parry is about officer naloxone training, officers carrying naloxone, officers understanding the role of harm reduction in an approach to overdose. If you start with smaller asks that kind of wedge your foot in the door, officers begin to see this other way of approaching the drug crisis besides arrest. And then that can grow a base of support that then becomes diversion from arrest, right? You don't have to start with the full Monty. You can go with other models, other methods, and Parry's, a good partner in that, and COSAP obviously as well. The other thing, right? So like methadone and buprenorphine, and I feel like I'm speaking to an audience that knows this, are opioids, right? Methadone is a fairly potent one, not as potent as heroin and oxy, for example, or fentanyl. And then buprenorphine is a much less potent one, but they are opioids. So one of the objections cops have is I'm just encouraging people to become addicted to one type of substance instead of another, right? And if a cop said that about a robbery recidivist, they wouldn't agree with that. If I said to them, there's a guy who's out there robbing convenience stores every other month, but instead he could become the type of guy who occasionally steals a bar of soap, you'd say that's a huge improvement. Let's do that, right? And buprenorphine is a hell of a lot better than even stealing a bar of soap. It allows people, I remind police officers, yes, it is an opioid, but it allows you to stay employed. It allows you to be a family caretaker. It allows you to stay housed. It allows you to be a fully functioning member of your community. I'm looking out my window. You can't see it, but the house right over there, my backyard neighbor, was on buprenorphine for a decade before I even knew it. And I was friends with him. He was fully functional. He was a boss at his own company. And I try to let cops know that. And then as far as diversion goes, there's a lot of evidence that trying buprenorphine, even illegally, so to speak, just trying it out, leads to, number one, reduced overdose. Number two, makes people more amenable to formal treatment. And I know I'm going on, I want to save some time, but I de facto decriminalized buprenorphine as a chief of police. I said, we're not arresting anybody for it. It's just, it makes no sense. I want them to try it, even if they try it quote unquote off label. And now Vermont and Rhode Island have formally decriminalized buprenorphine and Suboxone. Just, it's not on the criminal law anymore. And I do have a grant from the National Institute on Drug Abuse to evaluate that. So I'm excited. Maybe next time, maybe I can come back next year and give you the results of that study.
That will be that. We're looking forward to that. Thank you. Let's take one last question from Andrea, and then we'll get on to our announcements.
We currently have, I work for the San Antonio Council on Alcohol and Drug Awareness, and we have a grant from HRSA for a rural opioid communities grant. And one of the things that we have heard of from other grantees is that officers want to refer and connect people to services right then, right there. And what we're hearing is that some officers need referrals, they need links, they need connection right then. So we're playing around with the idea of creating a referral code or a QR code on the back of some information, brochure, something to give to the officers that they can refer directly to service providers in the area. And then we would follow up with the person that they made contact with fairly quickly. So that's something that we're hearing and that we're really wanting to work on and implement.
Yeah, Andrew, I love that idea. Just it kind of meshes with my closing observation, which is that the process by which cops arrest people is like entrenched and well developed, and it's not a model of efficiency, but it's a heck of a lot more efficient than other things we're asking cops to do. And anything you could do that'll bring deflection or diversion or linkage like on par with that is a step in the right direction. It also is a signal that you're taking it seriously. Like if you tell cops, I want, not you per se, Andrea, right? But if you tell cops, I want you to take this seriously, but I'm not going to fund it and it's going to be hard to do and it's only going to work certain times. That's all the other signals are that you're soft pedaling, right? So that I can't solve that, but I do bring that up as a barrier to making this on par with arrest.
Yeah, and we've got some really great law enforcement that we're working with. They're very, very progressive in their thinking. So it's
great.
To their credit.
Well, that's great. And that idea of sort of continuity of communication and collaborating, that leads right into our case for today. Before we get into that, let's just do some quick announcements from the Be Well program. Thank you, Cato. If you're new to Be Well Texas, just a little bit more about it. This is a welcoming environment with caring professionals ready to help people start or continue their journey towards recovery. Be Well Texas is committed to expanding equitable access to compassionate, evidence-based care for substance use disorder throughout Texas. Next slide. Mark your calendars and register. Join us for the 5th annual Texas Substance Use Symposium, Texas, on March 27th and 28th at the Henry B. Gonzalez Convention Center here in San Antonio. This is a free event and it includes complimentary continuing education credits. Learn more about the whole event at their website, texas.org. That's txsus.org. Next slide. Texas is also accepting exhibitor and sponsorship applications. 100% of the support they receive provides free continuing education for the symposium attendees, helps to fund travel grants for experts in the field, and helps to underwrite other event-related costs. You can learn more about this at the links that are being dropped over in the chat right now, texas.org/sponsor-Texas. Next slide. And we hope you'll join us Wednesday, February 15th, next week for the next Texas sessions featuring Dr. Cortez. To register, just go to texas.org again /sessions, which Cato just dropped over in the chat. Thank you. Okay, so let's get into our case. We've got a great one today. Lisa and Cynthia, Echo IT is going to share the case as soon as you see that. Talk us through this case and the challenges and the questions you have for this community.
Okay.
Okay, I'll get started. Again, my name is Lisa Neal and I'm with the United States Probation Office. And so Cindy and I chose this case, and the questions that we have, and this came up because there were barriers that came up with this case. So the questions that we have are, what are the responsibilities of a hospital to any treatment resources when an individual has overdosed, been admitted, and then discharges? Also, if a person tells the hospital staff they're on supervision, what is the hospital's responsibility, if any, in notifying the probation officer, knowing that we have a release?
So the setting and context of this encounter, this person was released from onto federal custody in February of 2020. He was referred to outpatient treatment and drug testing. He was ordered, and this was ordered by the court. This was a condition of his supervised release. He was ordered for mental health treatment and a psych eval. And at that time, he was residing with his sister and brother-in-law. And he was diagnosed, according to the information we had, with co-occurring treatment. He needed diagnosed with general anxiety disorder and ADHD. So brief description, as you all remember, February of 2020 was the onset of everything shutting down with COVID. In this encounter, he had COVID. He was staying away from his family because they had high health issues. And so he was staying with negative associations. He was using heroin for approximately 3 weeks that we are aware of. He overdosed, EMS was called, he was taken to the hospital. And then when he was released and discharged from the hospital, he went to go and live at a hotel.
So the next question is, what strategies did you employ to manage the encounter? Conditions of supervision were modified to include a 90-day residential inpatient program, an alcohol abstinence condition, 120 days at a residential reentry center, which is a halfway house, and a program that offered medication for opioid use disorder.
Standing operating procedure, we have variety. There is no one standing operating procedure, but there are lots of guidelines, obviously. So our office uses graduated sanctions while continuing to use any available resources, depending obviously on the specific case. We can modify their probation conditions and try to continue to work with this person under supervision. We can request a warrant. We could go back to court, and then at that time recommend revocation or some other treatment option to the judge. Again, we have a variety of judges. We just don't have one. So this procedure depends on the judge. What is the judge inclined to do? Or what is the judge inclined not to do? And then the substances involved in this particular individual was heroin.
Okay, and then the relevant context about this person, like Cindy said, this was the onset of COVID, and so there were a lot of restrictions and barriers, but there was stable housing and a stable family support system. There was poor past antisocial peer and associations. As far as COVID related, it was difficult for him to find employment. And because of COVID, probation officers at the time, at least for our office, were not doing any in-person home visits or drug testing. The barriers, what barriers did you face in the encounter? Obtaining information from the hospital. And then as far as COVID related, again, the unemployment, and he didn't have an ID or a Social Security, and the Social Security office was closed and backlogged. So those were all barriers.
What went well? Well, he had very strong family support from his sister, his brother-in-law, and another sister. So both of his sisters, brother-in-law. We had available resources from our office. We had inpatient treatment, outpatient substance abuse treatment, and mental health treatment. We had the halfway house when the halfway house didn't have a waiting list like they do now. We also have a program that we call Trexan. It's a medication program, such as the doctor was speaking about earlier. We had psychiatric and medication services. So we had a good amount of resources to use. What would we do differently? we went back and forth on this, and we're not sure what we could have done differently in the path that it took, that this person took. I don't think we would have done anything differently.
Great, thank you, Cynthia, Lisa, so much for that. And I want to ask Echo IT, just scroll back up to the top, and if you could remind us again of kind of the questions that this learning community can be navigating with you.
Okay.
Great, thank you. So, go ahead.
There's a question. Do y'all refer to nonprofits for recovery coaching? We are, because of the state of the economy, we're on a very strict budget for the next year to 2-3 years from what we've been told. So we are relying heavily on our community resources. We refer a lot of people to Cicada, so thank you. We do refer people to Cicada and any available resources that we have for not just substance use, but for any kind of mental health needs as well.
Thank you. Let's open up the room. Any questions, any other questions for Cynthia and Lisa about this case?
So I was just going to make a comment, it's Dr. Miramontes, about the hospitals. So you folks in corrections are really basically handcuffed about knowing when your charges are in the hospital. So under HIPAA, the hospital is not allowed to release any information to law enforcement except for some very narrow circumstances.
Mm-hmm.
On the other hand, and I put that in the chat actually. On the other hand, if the charge or the person in probation or inmate allows that information, permission to talk to their case manager, their probation officer, or whoever, then that information is allowable. But you guys are really stuck because you don't know when your probationers are in the hospital or have gotten sick. And there's no real way to do that right now. Now, on the other hand, we need to make sure that the people that are under our care, those on probation, know that or have a relationship with their probation officer or their clinician, that they could say comfortably, hey, I slipped up. I was in the hospital. I almost died. I need help. Right. And unfortunately, they're stuck between a rock and a hard spot. They know they need help. They know they need care, but they're afraid of going back to jail or prison. And that is a really bad space to be in. So I just want to make sure that the other folks in the community know the patient's in the middle of the worst of two options, right? They know they want to get help, but they can't because they don't want to go back to prison. And unfortunately it would seem, except for some great innovative places that our speaker we're talking about, that there's not a lot of wiggle room in there. So can a probation officer get information from the hospital? Yes. Is it going to be in real time? No. It's going to actually be a real pain in the butt because you're going to have to send a copy of the release. You're going to have to send this terrible form that every hospital has for release of information. And it might be weeks until you get what happened to that person. So unfortunately, if you're relying on a hospital to give you information, not going to happen. But we do need to empower the people in our care, our patients, our probationers, to be comfortable and saying, look, I screwed up, I need help. And that's the tough part. So
well, we were fortunate to obtain a little bit of information from the hospital, but what was really helpful was the family, the sister that helped. And so, excuse me, one of the biggest questions is, we always say if the offender, the person on supervision, under supervision, is not under our supervision, what would have happened? What would have been the responsibility of the hospital, if any, if they would have been released? And that's it. We had the resources. He was on supervision. Had he not been, then what would have happened?
Yeah, so this is really a sad state of affairs. It depends. For example, in the San Antonio area, there's really only one hospital system that's engaged in this space of starting Suboxone, referring to Be Well, Texas, and engaging that. So you would think that they would have a requirement or an obligation to put to refer people to care. And I have to say, the sad news is that in most places that doesn't happen. Right. So that's the sad part. Now, are there resources? Yes. Almost every city in the United States has the resources. The problem is linking the client to those resources. So people like Cicada and Be Well and wherever you have in your area, is making sure those ERs, especially, and that the social workers in the hospital, if they're admitted, know that those resources exist and that you have access to them. That's the key. So you may have to go, our referring agencies have to constantly re-educate hospitals, social workers, and ER staff that these resources are available, and hopefully they'll nudge them to get patients into treatment.
Yeah, it brings to mind that I think Dr. Del Pozo showed, he called it the squid graphic, and that sort of later down in the line and how much more fragmented and challenging everything gets. And you just sort of see patients falling through there. Really powerful visual.
The other thing to add, I was going to add real quick, is that if you have a clinician or physician, mental health worker, someone that's engaged with that client, they're allowed to get that information through continuity of care provisions of HIPAA. And most of your clients sign a release anyway, right? As a condition of their monitoring. So yeah, a clinician at any time can ask for a request for information about their patient from another provider, physician, hospital, even EMS. They're allowed to ask for continuity of care.
Good point. Sandra, you dropped a few acronyms, I guess, services in the chat. I wonder if you might unmute and talk to us a little bit about those agencies, those organizations.
That's our coworker. Sandra Ross, are you there? Okay, we'll help her out until she gets on.
Okay.
One of them, oh, there she is. There you go.
Sorry, I closed my laptop and I just had the screens open. Yes, we do use a variation of nonprofits, their mental health, substance abuse, or also we use recovery, lifetime recovery. So there's an outsource with Recovery Links. We have CHCS. And both the ladies that are talking, Ms. Cynthia Gonzalez and Lisa Neal, also work as liaisons to residential facilities. So those residential facilities provide aftercare programs, and they're also linked to several community resources. So I just wanted to let you guys know about those.
Great, thank you. Other questions for this team about this case, or shared experiences or challenges? Oh, go ahead. Oh, sorry, that might have been just Sandra remuting. Other questions for the team about this case?
I was going to ask, what interventions did you do for this client on discharge from prison? Did he get Narcan? Did he get a mandatory substance abuse evaluation? Did he get what interventions were done on release from prison? This patient you're talking about is unfortunately the most highest risk person to die in the first year of release from prison from substance abuse disorder. So tell me a little bit about what kind of interventions that you did or could have done that may have helped him to succeed.
One of the first things that was done, because it was court ordered, we can't make them do anything that's not court ordered, was a psychiatric evaluation. And a psychiatric evaluation was conducted, found to be that he needed treatment and on medication. So that resource that's a high resource we take care of, because many of our people on supervision need that. Psychiatric evaluation and medication monitoring. And then Ms. Neal, you want to talk about the substance abuse?
Well, one thing I'll add is a lot of times we go based on what the court has ordered at the time of sentencing. When we see that somebody is about to get out, and we can see as an officer, based on information that we have available to us that they have a substance abuse history, we can approach the case manager at BOP and we can let them know, look, we'll accept this, we'll approve the pre-release. However, we want them to, agree to modify conditions to include substance abuse treatment. That wasn't necessarily the case with this gentleman, but I'm just saying when somebody is getting out, we really do go based on what the court orders. But as an officer, we can ask the individual to amend. They may not always agree to the amending of conditions. So it's just kind of a hit or miss. Usually they do.
The issue with this person is it was literally the beginning of COVID shut down. So he was released. We referred him for an appointment and everything shut down. Nothing was done in person. So his assessment, his substance use disorder assessment, his mental health treatment, all that was done virtually or by telephone. And you all well know sometimes these type of individuals need that one-on-one in, face-to-face, eye-to-eye type of conversation. So that's what was done to begin with, the mental health and the substance abuse.
So if I can add to what these ladies are talking about also is that just for understanding, the court just doesn't arbitrarily say you're going to have a substance use treatment condition or a mental health condition. Usually a lot of that is staffed with some of our specialists. We have people that have specialty backgrounds in mental health and substance use treatment. And so they staff that with some of the officers that are recommending certain conditions. So there's a lot of prep work that's done with our specialists who know who have a background in those areas. And when they are releasing from the prison system, those specialists then staff with some of the other treatment contractors and specialists that we have. For example, they may be in treatment with a mental health or substance use counselors before they come out of prison while they're transitioning from the halfway house. So our officers sit down and staff some of those conditions or the needs for some of those treatment services.
Thank you, Cynthia. That's really helpful context.
Just to add to what Cindy is saying also, so a lot of times the communication between the probation office and the Bureau of Prisons is key, because a lot of times if they have major mental health issues, we want to make sure that when they're released, they come with medication, because it might buy us some time to get them into treatment. It doesn't happen automatically. A lot of times there's a wait. So if they come with medication, that's a big plus for us. So if we see those issues are going on, like I said, we can reach out to the Bureau of Case Managers and the Bureau of Prisons case managers and ask them to make sure they're released with something. Often they're not, they don't come with anything.
And then you have to start.
Right.
From
Right.
Well, thank you for the case. I'm gonna, just in the interest of time, I'm gonna turn things over to Jeremiah to summarize some of the key points from our conversation today. Go ahead.
Sure. Thank you, Andrea. And thanks everybody for this. Today has been really, really interesting. Having the wise words and experience of folks who, senior in law enforcement, senior in probation, different aspects. You've got on the law enforcement side, how do you, through a deflection diversion program, get people referred into treatment, or provide people with some resources so that they can themselves access treatment if they're interested in it, if they're ready for it. And the challenge of educating law enforcement agencies about these opportunities and about what treatment is, how it can work. And it's really impressive public safety improvements, because if this sort of overwhelming conversation here is that we're talking about public safety and public health, and how do we turn it into something more than just words, right? There are all these actual kind of granular details to just figure out how do you actually make this work. So Brandon get this on general understanding for folks who might not have been aware of how effective this is, how fighting addiction fights crime, right? So, but then you have in that sequential intercept model, right? You've got all the different points. Then, the situation with probation is obviously very different. You've got people kind of, already under supervision, and then, well, there's an overweening aspect of, some judicial court conditions are. Conditions of probation are more patient-centered than others. Kind of depends on the system, depends on the judge. Is in some systems, particularly, I think we probably see this more at the state level and the federal level. Is my guess is that where judges and other court officials take on the role of clinician in making decisions that actually really belong with a clinician, and having a wider recognition of the different types of medications if they're open to medication, because they're only thinking about naltrexone, whereas there are multiple options, and finding what's patient-centered and effective at that person's stage of change. But then you get someone into a treatment cycle, there are going to be bumps in the road, right? I mean, a return to use is predictable. In here the case with we have the COVID context that adds the COVID aspect to it, but return to use is part of the definition of addiction, right? It's part of what we expect. And so how do you get feedback to the probation officers so they can make adjustments? Of course, recognizing that sometimes people don't want to provide the feedback because they're afraid that they're throwing the patient under the bus if they're going to get a technical violation out of it. And you've got good probation officers who are like, I need to know if someone's having a problem in a road bump so we can deal with that. Threading those needles is really challenging, and then you get into HIPAA rules, and you get into people being overworked, and what kind of boxes are getting checked, if there is a checklist at all to check. I think kind of leaves it, or we haven't really answered all the questions here today, but have highlighted a bunch of the issues to address in order to make sure we've got a decent continuity of care for folks who need it. Also it's really cool to see how many people here are actively interested, actively participating in related programs, or looking to develop some, or make connections across sectors, so we can get a solid cross-sector collaboration going, which is of course part of the whole idea of us all gathering together in this kind of a context. So I'm sure I've missed a bunch of key points, but it's been a great conversation today.
Very thorough. No, Jeremiah, thanks so much for the wrap up. A special thanks to our presenters, including Dr. Del Pozo, and to Cynthia and Lisa, and also Sandra for presenting on this case today. Thanks to our hub team. As always, the biggest thanks to all of you who keep showing up with your questions and your experiences to help us all grow in this space. We look forward to seeing you at our next session, Thursday, March 9th at 11 a.m. Central. Until then, have a great rest of your week. Bye.
Thank you.